Ladies and gentlemen, good afternoon and welcome to this scientific symposium dedicated to new reagents, innovation and medical added value. My name is Bruno Pougot and my position is Global Hemostasis Manager at HORIBA Medical. But firstly, I would like to thank our three hemostasis specialists that will present the last studies. Dr. Annette Bowyer from the University Hospital of Sheffield will talk about the scientific aspect of APTT reagent in the assessment of coagulation. Dr. Pierre Suchon from the University Hospital of Marseille we talk about the last update concerning diagnosis, proteins regarding the clinical and the biological aspects. And Dr. Laurie Talon from the University Hospital of Clermont-Ferrand, we talk about a new D-dimer reagent, the assessment of a new D-dimer reagent. Please, Dr. Annette Bowyer, the floor is yours for the first presentation.
Thank you very much, Bruno, and thank you for the invite to present today. I'm delighted to be here in person. I'm going to give a bit of an overview on why we use the APTT, what it does, what the functions, and whether it's still fit for purpose in this day and age. Just get a printer. So these are my disclosure. I'm going to start with a little bit of history into why the APTT came about. So the discovery of clotting factors in the blood led to their measurement. Initially, this was a whole blood clotting time, followed by a plasma clotting time. And the PTT, as we almost know it, was first used to aid Ken Brinkhouse in the characterization and purification of factor VIII back in the 1950s. And this was a crude extract of rabbit brain. It was noted in the early 1950s that the PTT was prolonged in patients with lupus erythematosus, and often this prolongation could not be corrected by addition of normal plasma. In 1953, the PTT was modified slightly using kephalin, platelet substitute, and calcium chloride. However, it was a very variable assay. And in the early 1960s, Rappaport wanted to monitor the purification of factor IX and considered that the PTT was too variable to be accurate. So he'd read that the use of kaolin shortened the PTT and made a more stable assay, and that became the APTT as we know it. This used kaolin as an activator. In the 1970s, unfractionated heparin became the therapy of choice for treatment of venous thromboembolism, and the APTT became the method to monitor the heparin in these patients. When we look at APTT reagents, we know that they are not all the same. There are differences in the activator, there are differences in the phospholipid profile and concentration. This table here is courtesy of UK NECRAS, which is an external quality assurance scheme run in the UK. And it's the results of an APTT sample that was distributed, and results were returned with greater than 900 laboratories. And overall, 18 different APTT reagents were used by these 900 laboratories. And I've highlighted in yellow the three most commonly used reagents, and they comprise a silica, an ellagic acid, and a polyphenol reagent, all with different concentrations of phospholipids and different sensitivities to heparin, to lupus, and to factor deficiencies. So the use of a contact activator such as kaolin speeds up the activation of factor XII and triggers the intrinsic pathway of coagulation. So does it matter which activator is present in your APTT reagent? Well, for most things, no, it doesn't. But work that's happened recently in the field of haemophilia indicates that, yes, it is important for some things. It's been known, for example, that APTT reagents that contain ellagic acid as an activator are largely insensitive to prekallikrein deficiencies, apart from the most severe deficiencies. So when we turn to look at measurement of factor 8 or factor 9 molecules, over the last 5 or 6 years, it's become quite apparent the differences between different APTT reagents when we come to measure these molecules in patients that have been treated with them. We know that some of the APTT reagents will grossly underestimate the concentration of factor 8 or factor 9 in the patient plasma, whereas other APTT reagents will grossly overestimate. And this can impact greatly on the treatment of these patients. If we turn to the phospholipid concentration of the APTT reagent, this is a really old slide, so some of these APTT reagents are no longer in use, but it does give you a bit of a snapshot of the phospholipid profile of our APTT reagents. So over on the left-hand side, these are increasing concentrations of sphingomyelin, phosphatidylcholine, phosphatidylserine, and phosphatidylethanolamine. In the middle here are a number of reagents that contain high concentrations of these phospholipids. You can see very dark banding. Whereas over on the right-hand side, these reagents are much less dense. They have a much lower concentration of phospholipid. And this graph here just shows the breakdown according to the phospholipid profiles of these reagents. So when do we need the APTT? Well, I spoke a little bit earlier about the monitoring of unfractionated heparin, which we do with an APTT reagent. But the APTT, if we remember, is affected by a number of pre-analytical variables, and this can influence the result. So for measurement of unfractionated heparin, really, a direct measure by the use of an APTT reagent is probably more accurate because it excludes things like elevated factor 8 activities or other coagulopathies that you see in very ill patients. The sensitivity between APTT reagents to heparin varies widely. Originally, the recommendation is that the APTT with a patient on unfractionated heparin should be approximately 1.5 to 2.5 times the mean normal APTT. However, if you have a patient that has a very strongly positive lupus anticoagulant, they will naturally have a higher APTT, and this can impact on the effectiveness or the dosing of heparin in these patients. So moving on to lupus anticoagulant. For some centres, the lupus anticoagulants are considered a laboratory nuisance. We're not interested in them. For other laboratories, they very much want to look at the lupus anticoagulant. So we can tailor the APTT reagent that we use in our laboratory depending on whether we want to look for these phospholipid binding antibodies or not. This is an example of a 28-year-old male who's previously had a pulmonary embolism. Turns out he has a prolonged APTT with one reagent, quite grossly prolonged, but a normal APTT with a second reagent. So why does this happen? Well, the reagent with the longer APTT has a much lower concentration of phospholipids and is more lupus sensitive than the reagent here with the normal APTT. So one way that we work in Sheffield, in my lab, is to run our APTTs with two different reagents if we are suspecting lupus anticoagulant. So we have a lupus sensitive and a lupus insensitive reagent. And when we have a look at this patient in a bit more detail and we perform a dilute Russell Viper venom test, we can see that it is indeed positive. And we can confirm this with a DRVVT that again contains a high concentration of phospholipids, because that will bind to the lupus anticoagulants and quench them and stop them interfering in these particular assays. One of the big bones of contention, or big areas of controversy, is whether we should perform an APTT as part of our preoperative screening for patients that are having surgery. This is an example of some of the literature that's been looked into whether it is effective and cost-effective and time-effective to perform a prothrombin to screen out abnormalities preoperatively. So there have been a number of these studies over the last 30 years. And I'm just going to look at one from 2017. This was an Italian cohort, and they measured the APTT using Synthesil, which is a low phospholipid lupus-sensitive reagent. They measured it in 8,000 consecutive patients that were scheduled for elective surgery. And of these patients, 97% had a normal APTT. With a ratio of less than 1.3. And 3% only had a prolongation to the APTT. And of these patients, these 3% of patients, 84% of them were lupus positive, so they had a positive lupus anticoagulant. There were a small number of patients that had factor 12 deficiency, not associated with bleeding. There was one patient that had a combined factor 11 and factor 12 deficiency. And there were 2 patients that had mild Haemophilia A, and they'd already been previously diagnosed with mild Haemophilia A. And then there was a small proportion of patients who, for whatever reason, were not followed up, so they don't know why they had a long APTT. So the authors of this paper concluded that for all of the patients that had, or most of the patients that had a prolonged APTT, this wasn't clinically relevant and wouldn't stop them going for surgery. The 2 patients that had the mild Haemophilia A were treated with factor 8 for their surgery, so they knew about that. If we have a look at the guidelines, obviously these are recommendations whether you need to measure an APTT prior to surgery. These from the BSH, the British Society of Hematology, recommend that patients with a negative bleeding history do not require routine coagulation screening prior to surgery. And I think the take-home point of this is that patients undergoing surgery should have a comprehensive bleeding history taken in pre-op screening, because this is a better indication of whether the patient's likely to bleed than performing an APTT. So the thing that we're really interested in around the surgery is whether patients with factor deficiency are going to bleed. And we know that different APTT reagents have different sensitivities to the different clotting factors. The CLSI guidelines from the United States suggest that the APTT should be prolonged if there is a clotting factor of less than 30 units per deciliter. But we know that there are many patients who will have a clotting factor of greater than 30 units per deciliter, for example, factor 8 or factor 9, who will indeed bleed. But this is what these guidelines suggest. So how much difference is there between the different APTT reagents that we have? So there's a paper out of France, and we've done some work in the UK looking at this. And this is done by spiking or artificially reducing normal plasma to different concentrations of clotting factor. And then we measure what the APTT is at these different concentrations, as we can see here. So the clotting factors have been altered from 0, so no clotting factor, up to about 100, serially diluted, and the factor 8, factor 9, and factor 12. So we measured the APTT of these with different reagents. The dashed line here is the bottom of the top of the reference range. So anything above this line is an abnormal APTT, and anything below the line is normal. And then we just take along from here and work out what the sensitivity is for each of the different reagents and clotting factors. And we can see that for both of these studies, I've highlighted in red that there are some reagents in which some of the clotting factors will actually be normal despite having a low clotting factor. So for example here, with this reagent, there's a factor 9 of 18. Here, the factor 9s are at about 10. So not good reagents to look for haemophilia B or haemophilia A. So I was asked about 3 years now, before COVID, to have a look at the sensitivity of 2 new APTT reagents by HORIBA, the Unison G APTT4 and the APTT Liquid4. These are micronized silica or ellagic acid reagents, optically clear. And I looked at the sensitivity, the APTT sensitivity in factor 8, factor 9, and factor 11. And these are the graphs for the 2 reagents, factor 8 in the red, factor 9 in the orange, and factor 11 in the blue. The top of the reference ranges are marked, and you can see that for the 2 reagents, there is a bit of difference between them. But for factor 8 and for factor 11, they agree with, or they are acceptable by the CLSI guidelines. For factor 9, I found some differences with all the different APTT reagents that I studied as part of this, some very commonly used reagents. And for factor 9, the sensitivity, more often than not, was much lower or a bit lower than the recommended 30 units per deciliter. So to summarize, a normal APTT does not always indicate normal hemostasis. There are a number of reasons why, including a very high factor 8 activity level, masking a low factor 11 or a low factor 9. The APTT shouldn't really be used as a screening test, but more as a diagnostic test, following a detailed bleeding history. APTT reagents vary in sensitivity to heparin, to lupus anticoagulants, and to factor deficiencies, depending on their constituents of the reagents. And the sensitivity of 2 new HORIBA reagents, the Unison G APTT4 and APTT Liquid4, were comparable to other commonly used APTT reagents for factor 8, factor 9, and factor 11. So with that, I would like to thank you for your attention, and I'm happy to take any questions.
Thank you so much for your very clear talk. We have a few minutes for 1 or 2 questions. Is there a question, please?
First of all, congratulations and wonderful insights on understanding the APTT variabilities. Myself, Dr. Prakash from India, Delhi. I have only one question, because we have seen the history of APTT getting, over the time, adding kaolin and many other reagents. So is it possible to add cephalin with other deficient plasmas coming from any other trademarks available?
So do you mean mixing and matching reagents from different manufacturers?
Sure.
Yes, it is possible. We do that quite a lot in my lab. But you have to be very careful to do a detailed validation verification, because you will be using them against the manufacturers, sometimes against the manufacturer's licensing or CE marking and so forth. So yes, you can, but you need to pay attention to your validation and verification. for it.
Thank you so much. Thank you.
One question, please. Professor Pierre Toulon, one question, please.
Can't hear you.
The mic,
It's
please.
not for Annette, but for people from HORIBA, because I was quite surprised by your last slide about APTT reagent from HORIBA, with different normal range or upper limit of the normal range between the two reagents. Is the composition different between
Yes.
Humus 4 and liquid 4, or is it only the formulation, one ready to use and the other?
Yes. Thank you for the question, Professor Pierre Toulon. It's mainly linked to the difference in composition regarding especially phospholipid concentration, because we also offer the both APTT for lupus anticoagulant test screening and confirmation in the APTT pathway. We have also the reagent for the derivative pathway, screening and confirmation, and those two one for the lupus anticoagulant screening and validation. And the main point is phospholipid concentration. Thank you. Thank you, Dr. Annette Bowyer. Thank you so much. I suppose very short one, because we have no many time. Sorry, please.
Yeah, Paul and Anderson, Reykjavik. I would like to disagree a little bit with Annette, because we've been told for over 30 years that you need that a good bleeding history is adequate prior to surgery. But people just don't take an adequate bleeding history. It never happens.
Yeah.
I've seen terrible cases where people did not take a bleeding history and did not take an APTT, and they ended up having hemophilia, they end up having arthrodesis, and a shortening of the leg. So I'm very much pro-measuring.
Okay.
Okay.
No, I do agree. If you can take a careful bleeding history, which you should do, but I do recognise that doesn't happen in many cases, and even in our lab it doesn't. But we have done a number of audits in our lab looking at, again, a similar thing. Do we need to do an APTT? Which patients are we missing if we don't perform an APTT? And it's very, very few in thousands and thousands, but they are the ones that are important. So I do recognise that. Yeah.
Thank you.
Can I really go now?
Thank you so much. We have to switch now to the next talk. Please, Dr. Pierre Suchon from the University Hospital of Marseille, that will let us know the last update regarding proteinase deficiency. Very important topic. Please, Dr. Suchon, the floor is yours.
Okay, thanks. Here are my disclosures. The diagnosis of proteinase deficiency is quite challenging, and we will illustrate that with two questions. First, what is the place of proteinase activity in the diagnosis strategy? And second, what is the correlation between proteinase rate and venous thrombosis risk? Protein S binds to C4b binding protein in the plasma for 60%. And this means that 40% of the protein S is free, and this is this part of the protein that acts as a cofactor for activated protein C. The protein S is encoded by POS1 gene, and it is a vitamin K dependent glycoprotein. So we will find a GLA domain, and we find also a thrombin sensitive region, EGF-like domains, and laminin G domains. Deleterious variations located on POS1 gene are responsible for proteinase deficiencies, and they cause severe thrombophilia, meaning that they are associated with venous thrombosis risk. This risk has been assessed mostly in family studies, and relatives with a deficiency have a 10-fold increased risk of venous thrombosis. Here is a quick view of the coagulation cascade. Free protein S acts as a cofactor of activated protein C in the inactivation of factor 5A and factor 8A, but it also acts as a cofactor of the tissue factor pathway inhibitor in the inhibition of factor 10A. Of note, this role is not evaluated by proteinase activity assays. So, what is the place of the proteinase activity in the diagnosis strategy? We can measure proteinase using three different ways. We can measure the cofactor activity using PT, PTT, or factor 10A based assays. Some labs use the free protein S antigen as a surrogate marker of this cofactor activity because this is the free part of the protein S that acts as a cofactor for APC. And we also can measure the total protein S. This is not a first intention test, but it can be used for the classification. We describe 3 types of deficiencies. Type 1 and 3 are quantitative deficiencies. They represent the vast majority of the protein S deficiencies, more than 95%. And they can be diagnosed using free protein S antigen assays. Type 2 deficiencies are qualitative deficiencies. They are very rare, less than 5% of all the deficiencies. And we need to use a protein S activity assay if we want to diagnose the deficiencies. So if you want a test capable of diagnosing all types of protein S deficiencies, you must choose a protein S activity assay. Although those tests come with limitations, and a major one is the high rate of false low protein S values, which is found in about 15% of normal individuals. So you can see the specificity is very poor. And we can add that the impact of the protein S activity assays on the diagnosis of protein S deficiencies is mild because type 2 deficiencies represent only a very small part of the deficiencies. And venous thrombosis risk associated with type 2 deficiencies has been poorly assessed. So, for all those reasons, a free protein S antigen in first intention can be an option. Here is a list of situations associated with a decreased level of protein S with both free protein S antigen and protein S activity. You can see, for example, pregnancy or vitamin K antagonist. And some situations are specific to the protein S activity assays. And for example, heparin, DOAX, and lupus anticoagulant can increase protein S level. And Factor V Leiden and elevated factor 8 are associated with a decreased level in protein S. So protein S measurement can be quite tricky, and you must keep in mind the situation if you want to make a good interpretation of your results. Here is a survey from the CAT Foundation. This is quite interesting because this will help us to understand the strategies of the different labs from the measurement of protein S. You can see that 171 labs participate to the protein S activity assay. This number is much higher for the free protein S antigen group with more than 300 participants. This let us think that the two strategies, either free protein S antigen or protein S activity in first intention, are probably well balanced between the different labs performing thrombophilia screening. And another interesting result of this survey is that the CVs for protein S activity are much higher, and this is particularly true for the low values of protein S. And you can see the CV was 24% for protein S activity, whereas it was 7% for the protein S antigen. So some labs make the choice not to use protein S activity in first intention, and they know that they won't be able to diagnose type 2 deficiencies, and this could be a major issue in some populations. And I will give you the example of the Japanese population. In this population, protein S deficiency is the most frequent inherited thrombophilia. It is found in about 2% of the general population, which is tenfold higher than in the European population. And this is mainly explained by the Tokushima variation that is found in 0.9% of the general population. This variant has been described only in the Japanese population, and it has been reported to associate with venous thrombosis. Of course, as a type 2 deficiency, it can be diagnosed only using a protein S activity assay. So the answer to the first question is not that simple. I would say that a strategy based on free protein S antigen in first intention is probably acceptable in most populations, but if we take the example of the Japanese population, this strategy won't work because there is a very high prevalence of type 2 deficiencies, and in this case, we need to use a proteinase activity assay in first intention. What about now the threshold that we should use for the diagnosis of inherited proteinase deficiency, and what is the correlation between proteinase rate and venous thrombosis risk? The cutoff that is currently used is about 60% depending on the lab and on age and sex. Some studies have demonstrated that this cutoff should probably be lower. We should lower this cutoff if we want to improve the specificity of the diagnosis. Here is an example on the left of a publication conducted on the general population. You can see that venous thrombosis risk increased for very low values of proteinase, way below 60%. And in this case, the threshold is probably around 30%. On the right, this is the results of a family study. And you can see that when we use the normal values for the cutoff, here is 65%. The specificity for venous thrombosis risk is very poor, it is only 50%. And when we use a 30% threshold, we improve the specificity for the venous thrombosis risk from 50 to 62% without losing any sensitivity. It goes from 88 to 85%. So the cutoff that will probably be clinically significant is closer to 30% according to those publications. Here is another way to ask the question, is there a correlation between proteinase rate and the type and the frequency of PROS1 variations? For this study, PROS1 gene has been sequenced in hundreds of patients with a suspicion of proteinase deficiency. And you can see that the lower the proteinase rate, the higher the prevalence of deleterious variations. And you can see that something is happening around 40%. Above this value, most patients won't have any deleterious variations. And below the 40% threshold, we found a deleterious variation for the majority of patients. So again, we should probably lower the cutoff for the diagnosis of proteinase deficiency. We can say also that there is a high prevalence of allele variation between 40 and 60% of proteinase rate. And the allele variant has been considered for a long time as a neutral variant, but our team has recently reported a 6-fold increased risk of venous thrombosis with the allele variant. And in the subpopulation from this study, we disposed of proteinase measurement in 1,200 patients, and you can see that mean proteinase was 20% lower in carriers of the variant allele as compared with non-carriers. And I must add that for this study, proteinase deficiency was an exclusion criteria. So we can conclude that the allele variant can be found in patients with normal values of proteinase. I would like to end this presentation with the strategy of the Marseille lab. We have chosen to measure proteinase using free proteinase antigen in first intention. But I'd like to add that we have a side strategy for young patients with severe unprovoked venous thrombosis episodes and a negative thrombophilia screening. For those patients, we perform a targeted panel of 23 genes related to the coagulation cascade, including the PROS1 gene. And we think that we should be able to catch up type 2 deficiencies that we would have missed because we don't measure proteinase activity. And you can see that we have identified 4 class 3 variations on PROS1 gene in patients with normal values of protein S, it will be interesting to measure protein S activity in those patients, and maybe we will find type 2 deficiencies. So in conclusion, there is probably a need for more sensitive and more specific functional assays that would allow the identification of all types of deficiencies in protein S. And there is probably a need for functional tests assessing TFPI-dependent anticoagulant activity. I have tried to answer the question about the threshold, but it remains unclear because the studies have demonstrated that we should lower the cutoff if we want to improve the specificity of the diagnosis. But we do identify variations in patients with mild deficiencies or even normal values of protein S. So we don't know what to do, and maybe the diagnosis of protein S deficiency shouldn't rely on measurement of plasmatic parameters only. Maybe we can wonder if there is room for genetics in first intention, and this strategy could be interesting for the early variant and maybe for the Tokushima variant in the Japanese population. Thank you for your attention.
Thank you so much, Dr. Pierre Suchon, for your very clear presentation on that major topic and the field of thrombophilia. Sorry, the time is very short. We have just time for one short question, please.
Well,
Professor Gris, please.
It will be short. Thank you very much, Dr. Suchon from Marseille. 3 little comments. The first one, what is your final recommendation on the practical use of protein S activity? First point. And second point, beside protein S deficiencies, I mean constitutional ones, what do we know about an hypothetic risk factor value of circulating protein S activity? I mean concerning all vascular events. If you forget constitutional inherited protein S deficiencies, is there any value in testing circulating protein S activity in order to predict any vascular event to be defined?
Okay, for the first question, thank you for your questions. I don't make recommendation because it's quite debated. We have chosen in Marseille to use a free protein S antigen, and I'm very okay with that choice because in the Caucasian population, I think it's quite acceptable, and protein S activity comes with so many limitations and bias of measure that it complicates the exploration. So for Caucasian population, I would say that this is probably a good choice in first intention. But I know this is really debated, and we can discuss it a little bit more. For the second question, I don't have data on those rates of protein S activity. I don't know if we can measure, for example, in a situation, in an at-risk situation, in order to evaluate the risk of a patient. I don't know if this has been done because it's quite tricky to measure protein S because many situations will alter protein S rate, and we don't know how to interpret those results. And I don't think there is a correlation that has been assessed for those situations.
Thank you so much, Dr. Pierre Suchon. We have now pleased to move to the next talk. Thank you, Dr. Laurie Talon, to introduce the next talk regarding D-dimer testing.
Hello, we are going to discuss about the analytical performance of a new immunoturbidimetric D-dimer assay, the Humizen GDDI2 assay, and its comparison with other available D-dimer assays. So thank you to give me the opportunity to share with you our results. Here is my link of interest. And let's start with some reminders about D-dimer. The D-dimer is a metabolite of fibrinolysis that increases as a result of hypercoagulability and hyperfibrinolysis. And many studies have shown that plasma D-dimer measurement can be a very safe and very effective parameter to exclude the diagnosis of deep vein thrombosis or pulmonary embolism. D-dimer assay is so widely used by clinicians to exclude venous thromboembolism, but D-dimer assays can also be used in many other cases for the biological diagnosis of systemic intravascular coagulation, to predict the risk of recurrence of venous thromboembolism, or to help define the optimal duration of anticoagulant treatment. Thus, D-dimer has become one of the most commonly requested coagulation tests, especially in venous thromboembolism setting. And currently, many different immunoturbidimetric D-dimer assays are available and are marketed in the routine practice. However, their reliability and performance can vary, and the main challenge for a D-dimer assay is related to the fact that D-dimer is not a standardized method, and D-dimer belong to a heterogeneous group of molecules. Available D-dimer assays differ in terms of antibody specificity, capture and detection methods, instrumentation required, result expressions, or calibration standards. And due to this heterogeneity, it's recommended to assess the analytical performance of a new D-dimer assay before its implementation in clinical strategies for venous thromboembolism diagnosis and monitoring. That's why the objective of our study was to evaluate the analytical performance of the new UMIZEN-G DDI2 assay performed with the UMIZEN-G 800 analyzer, and then to compare the performance of this assay with other available D-dimer assays, such as Vidas D-dimer exclusion 2, Liates DDI+, Inovance D-dimer, and Hemosil D-dimer. About the analytical evaluation, imprecision was evaluated by running repeat assays using low and high quality control plasma samples. The within run ranges between 1.7 and 5.8%, and the between run ranges between 2.8 and 5.5%. These coefficient of variation values are in accordance with the specifications by Ricos and colleagues, and in particular, we can note that the assay imprecision for plasma samples with value around the threshold of 500 nanogram per milliliter is satisfying. The limit of detection, limit of quantification, and linearity were determined according to the Clinical and Laboratory Standard Institute. And the upper and lower limit of detection limits were comparable to those of the other assays. And the linearity is very good for a broad range of concentrations, up to 32,000 nanogram per milliliter fibrinogen equivalent unit. And this wide linear range allows the direct measurement of most clinical samples without the need for manual dilution, therefore decreasing the turnaround time. Then, knowing that D-dimer immunoassays can be impacted by interference from hemolysis, icterus, and lipemia, we have evaluated the UMIZEN-G DDI2 assay for each of these interferences by spiking plasmas with hemolysate, bilirubin, and intralipid. Hemolysis represents the most frequent interference in coagulation laboratory and represents around 4% of all samples received. It's less than 1% for icterus or lipemia. The figure on the screen represents the bias in D-dimer measurement in function of hemoglobin levels. Dotted lines represent the acceptable bias, the limits of acceptable bias. Each color corresponds to one plasma sample, and the different points correspond to different hemoglobin concentrations. So here we can see that hemoglobin doesn't have any impact on the D-dimer measurement up to the hemoglobin concentration of 10 grams per liter, which is greater than described for the other assays. We have made the similar test with bilirubin and intralipid overload. And here we can see that icterus doesn't exert any analytical impact on D-dimer measurement up to the highest bilirubin concentration tested of 300 milligrams per liter, which is in line with the other immunoassays tested. About intralipid, D-dimer measurement seem to be underestimated when intralipid concentration is greater than 5 grams per liter, especially for values for low values of D-dimer. Always about interference, the occurrence of interfering heterophilic antibodies has been, with the antibody of the D-dimer assay, has been described in the literature and can be responsible for false positive or false negative results with meaningful clinical implications. So we have evaluated the impact of human anti-mouse antibodies at a concentration of 500 nanograms per milliliter and rheumatoid factor at a concentration of 1,000 units per milliliter using 10 plasma samples. And we can see that AMA and rheumatoid factor doesn't have any impact on the D-dimer measurement, supporting the safety of the Humizan GDDI2 assay. Then about the comparison study, it was carried on fresh citrated plasma samples from 66 consecutive routine patients with a wide range of D-dimer concentration. And all of these plasma samples were tested with different analyzer reagent combinations that you can see here. All of these samples were performed according to the manufacturer's instructions. The same unit, nanogram per milliliter FEU, and the same usual clinical cutoff value of 500 nanogram per milliliter are used for all of these assays. And these comparisons are presented on a Bland-Altman plot analysis. So here you can see the Bland-Altman plot analysis for the comparison with the Humizan GDDI2 assay and the currently proposed reference method, the VIDAS D-dimer exclusion 2. The x-axis represents the mean of the D-dimer values obtained with these two methods, and the y-axis represents the difference between the D-dimer values obtained with these two methods. Dotted lines represent the bias and the upper and lower limits of agreement. And here we can see high comparability between the Humizan GDDI2 assay and the VIDAS D-dimer exclusion 2, with a mean bias of 81 nanograms per milliliter. If considering only values below 1,000 nanograms per milliliter FEU, there is also high comparability between these two methods. You can see some discordant points around the clinical cutoff value of 500 nanograms per milliliter FEU, but none of these patients developed thrombosis. Here there are the Bland-Altman plot analysis of the comparison between the Humizan GDDI2 assay and the STA-ILIA test DDI+, the Inovance D-dimer, and the Hemosil D-dimer. And the D-dimer values are slightly lower with the Humizan GDDI2 assay, with negative mean bias. But overall, we can say that there is a good agreement between the Humizan GDDI2 assay and the other available assays tested, even if some variability persists. And as I told us, this variability can be explained by the heterogeneity in antibody specificity, capture and detection methods, calibration, and so on. In conclusion, the analytical performance and technical features of the Humizan GDDI2 assay make it a suitable method for the rapid quantification of D-dimer in clinical laboratories. This reagent is designed for the hemostasis, for the Humizan G hemostasis range analyzer, from semi-automatic to fully automatic analyzers, which covers the need for any laboratory. And there is high comparability with other immunoassays. Eventually, in the future, these results should be clinically validated to prove the accuracy in the diagnostic workup of patients. So thank you for your attention.
Dr. Laurie Talon, thank you for your assessment of this new reagent and for your very interesting presentation. Is there any question, please?
That's a very brief question. So thank you very much, Dr. Talon from Clermont-Ferrand. Well, as you know, some immunoturbidimetric D-dimer assays have been sometimes demonstrated to be insufficient for exclusion of distal DVTs. I precise, exclusion of some distal DVTs. Do you have any data with this new assay?
No, I have no data on this. But D-dimer assay has to be measured only in low and moderate risk of thrombosis.
No, thank you for the question. We are new. It's a new region. Is to be assessed. Yes, thank you.
Yeah, just a small question about
Yes,
the systematic negative bias between the results obtained with your reagents versus all the comparators. Do you think there could be some difference in the calibration values or some other reasons? Because all the other comparators provide lower or higher values than the HORIBA one.
Professor Pierre Toulon, it's come mainly from, as you know, of course, the dimer testing use different antibodies, company to company, and it's because the dimer, as you know, is an heterogeneous family group. Depending on the size of the D-dimer can be different, and it comes from the nature of antibody used. And but the threshold is the same for and validated 0.5 for exclusion of thromboembolism. This is the main point. The threshold used is the same, but what you mentioned is mainly linked to the nature of the antibody.
Okay.
One additional question, the last one, please. The last question.
Thank you for your nice presentation. It was very clear. I'm Shubham from HORIBA, France. You mentioned as per CLSI guideline, the LOB and LOD is 52 and 64 respectively. So in this case, this reagent can be used with the HER2 score?
Yes, D-dimer is a component of the HER2 score with a cutoff value of 250 nanogram per milliliter. So from an analytical point of view, the limit of detection of the Humisan GDDI2 assay is satisfying to be used in this score. However, this score has been validated only with the VIDAS D-dimer exclusion 2. So maybe there is a question whether if any other immunoassays can be used in this score. So maybe it could be useful to evaluate this reagent to be sure that this reagent can be used in this score.
Thank you.
Thank you.
Thank you.
Thank you very much.
It's very clear. Thank you so much, Dr. Laurie Talon. Thank you so much, Dr. Pierre Suchon and Dr. Annette Bowyer. Thank you all the attendees. We wish for you a very good ISTH Congress. Thank you.